Welcome, everyone. Um, so today, it's an interesting day, 2 days after the election, and I'm going to take this off so you can see it. So this is a campaign button. 72 years ago in 1948, there's another contested presidential election. Harry Truman, they believed Harry Truman had lost the presidency in 1948 because that was the first time he'd run on his own. And this is actually a real election button for Truman. But in fact, he did win. The newspapers had just prematurely announced his defeat. And so there's a kind of famous picture of him holding up the newspaper with the other guy's name in the headline, but really he won. And I bring up Truman today because this is absolutely not the first time that we have experienced a very divided political situation in America, one where it seemed like nothing could get done in Congress. But I do want to offer some hope because Truman did manage to get elected. And he is my personal favorite president. I'm not to say that he didn't have some downsides. He has been criticized, for instance, for his decision to drop the atomic bomb at the end of World War II. But I like him because he is the first president who came out full force for fully equal civil rights for Americans. He issued the executive order that desegregated the U.S. military in 1947. He was the first president to address the National Association for the Advancement of Colored People. I believe that was in 1946. And he also was the first president to come out full force for national health insurance. And all of those things actually were related. He was a very astute politician, and he had been elected senator from Missouri. So he was from a segregated southern state, but he had been elected senator from Missouri, and he recognized that it was the Black vote in St. Louis and Kansas City that had put him over the top to get elected. And so both for political reasons, he saw that Blacks were a rising political force in the United States, and I think for ethical reasons, he truly believed in equal civil rights for all Americans. He is really, in a lot of ways, a major turning point in American politics. So I thought that would be interesting to some of you based on the current election that we see ourselves in today. And that also is a good introduction that the issues of national health insurance and civil rights were very, very closely interlinked. And I'm going to try to give you an idea today of why that was and how that played out in some of our national health policy in the 30s, 40s, and 50s. And I'm also going to really highlight today the role of African-American health professionals, particularly doctors and nurses, in fighting for both civil rights and equal access to health care during a time, I would like to remind you, when in Congress, when the NAACP and other groups attempted to lobby for an anti-lynching law, a federal anti-lynching law, it was blocked, especially by the Southern segregationist congressional delegation. So because the South at that time was completely dominated by the segregationist Democratic Party, the Democratic Party used to have a northern wing and a very segregationist conservative southern wing, who later on in the 20th century goes over to the Republican Party. But at this time, these Democrats in Congress could block most any piece of legislation they decided they didn't like. And so they blocked anti-lynching. They blocked fair housing legislation. They blocked a lot of what could have become additional pieces of the New Deal. but they didn't block a lot of the health legislation. And that's in part because of the really successful lobbying of groups such as the National Medical Association, the National Urban League, the National Negro Congress, Alpha Kappa Alpha Sorority. There were all these national African-American groups that were fighting very hard to get healthcare access improved, not only for African Americans, but for people all across the United States. So I want to try to explain, like, why was health a big exception in national policy during this time when it just seemed like a lot of things were not getting passed? We talked about what Thomas Morell said in the Journal of the American Medical Association in 1910, that this was a mainstream medical journal and that this article was quite influential. And it was printed at the height of scientific racism. So we talked a good bit about what white scientific racists thought last week. But this week, I'm going to begin with a response to that horrific article that was published in the Journal of the National Medical Association by John Kenney, who was a leading Black physician and leader in. So the National Medical Association was the African-American counterpart of the American Medical Association. And this article that he wrote was also published in 1910. And so part of what's going on here is the history of professionalization of medicine. The AMA was not very powerful early in the 20th century. They really don't get going until the 30s and 40s. And one of the ways they really try to establish their strength and visibility is by opposing national health insurance. However, John Kenney really takes Morell to task in this 1910 article. So the medical associations, there were local, state, national organizations, and I don't know, for kind of the average person out in the United States, I'm not sure if most people have heard of the National Medical Association, but it is a very venerable and active medical association that has been really fighting for equal access and justice in healthcare for over a century. And I read an awful lot of issues of their journal when I was writing my book. So here's what he says. Our object is to publish a first-class medical journal, not a Negro journal. In other words, they're not just trying to reach an audience of only African Americans. There are hundreds of medical publications by the white race, but we're the only medical spokesman for the Negro anywhere in the world. When men high in the medical profession, Thomas Morell, use the leading medical journals of the country to assail and libel a whole race of people, it's time that our publication should speak and speak plainly. So Kenney and many other leaders in the National Medical Association, as well as organizations such as the National Association of Colored Graduate Nurses, that was the Black Nurses National Professional Association, they were all, they were fighting for their own professional legitimacy, just like the AMA was. And they were trying to encourage patients to get regular checkups and come to their offices and pay fee-for-service medicine and all of that at a time when medicine didn't necessarily have a lot to offer in terms of they couldn't treat or prevent a lot of diseases, but medical knowledge and scientific knowledge was definitely advancing. And so the professionalization of American medicine really plays out alongside the civil rights movement and the imposition of segregation and disfranchisement. While a lot of what I'm going to say does apply across the nation, I'm going to focus a lot on the segregated South today. and why this particular region was so influential on our broader national civil rights and health policy. And I think, there's some kind of obvious reasons for that. So when we look at the medically underserved populations in 1940, there were 37 million people that lived in the South. And of those Southerners, it was a little over a quarter of the US population, but 41% of Southerners lived in rural areas. So the South was more rural than the rest of the country, and 27% of Southerners were Black. Then we look at rural Americans. A quarter of the US was rural compared to 41% in the South, but half of rural Americans lived in the South. So the South, suffice it to say, was a very rural area. It was also the poorest by far per capita income in all of the United States. And finally, there were approximately 13 million African Americans. And at that time, that was about 1/10 of the US population. But, and this is something a lot of people aren't necessarily aware of, 3/4 of African Americans still lived in the South in 1940. And of those 13 million African Americans, half of all African Americans lived in the rural South. So when we're talking about health disparities and the conditions that many African Americans faced, it really is important to pay attention to what was going on in the rural South. Now, with the Great Migration, so if you've read the book, The Warmth of Other Suns, and a number of other books, there's going to be a massive exodus out of the South that's already starting before World War II, but it really intensifies during and after World War II as job opportunities open up outside the South and agriculture in the South begins to really decline. So that's just a quick overview. So this is a photograph from 1951 in US News of 3 students at Meharry Medical College in Nashville, Tennessee. So I have this photo to illustrate that until white medical schools began to desegregate in the 1950s, even in the North, where they weren't segregated, but even in the North, medical schools like Harvard, Yale, Columbia, they had quotas. They had quotas for Jews and they had quotas for Blacks. So there are only really token numbers of minorities, ethnic and racial minorities, being accepted to medical school in some of these more prominent medical schools outside the South. In the South, all of the white-run medical schools, both private and public, including Johns Hopkins, were closed to African Americans. And our school, the School of Public Health, where I'm the historian, we admitted the first Black student in 1945, and he became the first graduate of Johns Hopkins who was African American in 1946. So that was very late in the game, but Hopkins was still among the first schools of public health to admit African Americans. So this meant, this was very important. So the only 2 schools, Howard University Medical School in Washington, D.C. and Meharry in Nashville, those were the only 2 medical schools that admitted students without prejudice and without racial discrimination. And they, of course, are still the primary producers of Black doctors even today. This is these are 3 of the leading members of the medical civil rights movement. On the left is Eugene Dibble of New Orleans. In the center is Lewis T. Wright of New York, and C.B. Powell, I believe, is at Tuskegee Institute in Tuskegee, Alabama. So I'm going to talk mainly today about Lewis Wright. He is in the center here. Lewis Wright I would say it's safe to say he was a prickly fellow. He was very opinionated, outspoken. He made a lot of people mad at him, but he was very, very effective in pushing hard to get better health care for African Americans. And he was a very vocal supporter of national health insurance. And somewhat, I just talked about the National Medical Association. Most of the doctors in the National Medical Association were from the South, and they tended to have been educated at Meharry, which was a somewhat more conservative Southern school in comparison to Howard. Lewis Wright had his MD from Howard, but then he was originally from Georgia, but he left the South and became the first African-American surgeon at Harlem Hospital in New York City. And he felt that the National Medical Association was too conservative, too slow, and wasn't, he felt like it was kind of too much of a club, or they weren't pushing hard enough and fast enough. And to be fair, if you were a Black doctor in the segregated South, it was dangerous. Now, Black doctors tended to be leaders of their local civil rights organizations and movements because they had more independence. They weren't going to lose their job if they stood out publicly against segregation, like many, many other Black Southerners would have. However, I'm just trying to tell you from the beginning, there were definitely differing points of view, even within the organized Black medicine. And so this is Lewis Wright. So he really sees national health insurance and national health reform as an area that Black doctors and really the NAACP and all African-American progressives should really be involved in. So he is president of the NAACP in the 1940s, and it is his primary drive as the president of the NAACP to really break apart medical discrimination and segregation, and also to get national health insurance passed, which unfortunately he is not able to do. So I'm going to talk a little bit about how Black health professionals really began to get more opportunity and really broaden their influence across the country. This is a photo of a lab tech in Harlem, New York City, in a chest clinic, and he's examining X-rays of lungs to look for tuberculosis. So tuberculosis was the leading cause of death in African Americans for a few decades into the 20th century, where by around 1900, it had really stopped being the leading cause of death for Americans generally. But because of the poor living conditions that many African Americans lived in, remember I was talking about people living in the rural South, we think of tuberculosis of being an urban disease, and it was. So in the slums and tenements of many cities, so both immigrants, African Americans, poor whites who lived in crowded, low standard of living in cities, they were getting tuberculosis. However, tuberculosis was also a really serious problem in the rural South because the housing was so dilapidated and so poor that families, it wasn't that they were crowded into a city, but large families were crowded very close together in these really shacks in the rural South. So more educational opportunities, more job opportunities begin to open up for Black health professionals, especially in the 1930s, because the New Deal begins to pour money into Southern state and local health departments to hire more health professionals generally, but there's actually an intentional effort to hire Blacks to reach out to deal with the health problems of the Black population. So within the New Deal, which is begun by Franklin Roosevelt after he takes office in 1933, the New Deal has race relations advisors. And this is a photograph of what was known as Roosevelt's Black Cabinet. So there were very prominent Black leaders who were brought in to advise the federal government on New Deal programs, particularly in health, housing, and education. And it was a simple recognition that the Depression had hit the South and African Americans particularly hard. And so if it was going to be successful, they would need to really meet the needs of the populations that had been most seriously affected. During the New Deal, there were programs to help farmers who had been hit very hard and early by the Depression. There were programs to provide housing, to simply provide food and relief. So these are some of the programs early in the New Deal. They set up temporary camps around the country in the fall of '33 as the weather was getting colder. And in the southern cities, they created separate Black units of these relief camps and centers. And they, although, you know, it was separate, it was not fully equal. They had somewhat a lower level of services, unfortunately, but it was a step toward recognizing the importance of meeting the needs across the board. And these camps that they set up, they included hospitals and medical care for people who had lost their jobs or lost their farms. And in the Farm Security Administration in particular, there were these medical care cooperatives that are really the pilot for what will become national health insurance legislation, and they serve thousands and thousands of people. And many Black families who were farmers were parts of those medical care cooperatives. So these are pictures of some of the New Deal health programs. So I had mentioned the chest clinic where I showed the technician a minute ago, that was funded by the Works Progress Association. And in New York, it was integrated. In New Orleans, even though it was federally funded, it was segregated. So the home nurses, the white home nurses would visit white homes and the Black home nurses would visit Black homes. This is a well baby clinic. So the clinic was staffed by Black doctors and nurses who were being hired by the Public Health Service and the state and local health agencies. So this was creating more jobs for Black health professionals. But Lincoln Hospital was a Black-run and staffed hospital in Durham, North Carolina. And during the early 20th century, there's a whole Black hospital movement that's really strong and gets off the ground. And it goes from doctors who basically open their homes and start using bedrooms in their houses to have patients stay overnight. And then they kind of leave their houses and the houses become small hospitals. And then the small hospitals with civic groups and fundraising become larger all Black hospitals. So this is in the private philanthropy sector. And some of these hospitals, including Lincoln, did get funding from Northern and Southern white philanthropy. So Lincoln Hospital received money from the Rosenwald Fund that was started by the founder of Sears Roebuck. And they also received some money from the Duke Endowment, which was started by the tobacco magnate Washington Duke. So there's different sources of money that are flowing into these Black hospitals and public health clinics. So that helps them grow considerably in the 30s and 40s. This is my grandfather, whom I mentioned last week, and he is doing a segregated white well baby clinic in Atlanta right around 1940. So even though, as I'm trying to show in these pictures, the growth of healthcare under the New Deal, and as medicine is getting more effective and more people want to pay for medicine, and for instance, in the 1930s, more women begin giving birth in hospitals. Previously, you would never have wanted to give birth to a baby in a hospital because it would be likely that you and or your baby might get sick or even die, because hospitals were not very nice places. But as money comes in and the facilities get better and cleaner and more modern, they become attractive to medical consumers. Both Blacks and whites begin to really patronize these hospitals. So although the medical and healthcare system is almost entirely segregated by race, especially in the South, public health is less so. Public health, because of wanting to use the funds as efficiently as possible, and because of the recognition that of the medically underserved populations, there are a lot of Black Southerners that are going to benefit from these programs, public health teams were, at least in some places, integrated. So here we have a white public health doctor. This guy is actually a graduate of our school, of the School of Public Health at Johns Hopkins, and later becomes Surgeon General, Leroy Burney, a white public health nurse, a Black public health nurse. And this is Thomas Perrin, who later becomes Surgeon General under Roosevelt in 1936. So what you see here is a mobile public health wagon that they are, it's a bus, and they're driving it out into the rural areas and giving immunizations, doing well child care and prenatal care. But a major push of these mobile clinics was to find and treat venereal disease, which in the rural South, generally, the rates were higher than in the cities, where it was perhaps easier to get treatment. So this is one of the early pushes of the New Deal with the Public Health Service. These are Life magazine photographs of Maud Callan, who was a really amazing public health nurse in South Carolina. So on the left here, you see some of the conditions that, especially in the rural South, that public health nurses and doctors had to deal with, but it was mainly the nurses. And the majority of public health nurses who took care of Black patients in the South were themselves Black. And the vast majority of midwives in the South were Black. And Black midwives took care of both white and Black families. And their services were really valued because most doctors were not going to come out into the remote areas. So on the right this is basically a homemade incubator for what was probably a premature infant, and the children are kind of looking in from the inside, but it is near the stove to stay warm, and it is in a makeshift crib because even back then they were trying to prevent infant mortality by the very common practice, especially in the rural South, of infants sleeping with their families. So this is Maud Callan. So the Public Health Service, and particularly the Social Security Act, has a very large public health section in it, and it really starts to create a national, full-fledged public health system across the rural South, where there had previously been very few public health services available. And so Maud Callan is training these midwives, and there had been folk midwives, but she is training them in more modern and more scientific midwifery that brings them into contact with a lot of kind of mainstream, doctors and nurses and health professionals who are working in these New Deal public health programs. So it really helps to elevate the status and the level of knowledge across the nursing and public health professions. And it includes a lot of Black midwives who really, they begin to get paid better, they begin to get better training, and so their professional status really improves. So by the eve of World War II, about 30% of all Southern counties employed Black public health nurses, but not as many employed Black doctors or dentists. And this really reflected the nature of power in medicine, that white doctors really held most of the power. And so they were okay with having Black public health nurses come in, but they were more resistant to having competition from Black doctors. And so even, for instance, in Birmingham, Alabama, just that one county employed 14 part-time Black physicians, 3 part-time Black dentists, and 16 full-time Black nurses. So it wasn't, they weren't excluded everywhere. There were pockets of areas where Black health professionals were really, really valued and employed. But a lot of other places, white physicians were more resistant. So Birmingham and then North Carolina probably employed per capita more Black health professionals in New Deal health programs than any other state. For instance, Mississippi, which had a very large Black population, had only 6 Black public health nurses in the entire state. So the way that both civil rights and national health insurance begins to shift is, of course, there's a lot of activism and a lot of state and local attempts to change laws and to expand healthcare and to fight segregation. So I'm not saying it just comes out of nowhere. But in 1938, there is a Supreme Court decision that you likely may not have heard of, but is actually, in my mind, just as important as Brown versus Board. And it puts the entire white South on notice that, despite what Plessy versus Ferguson says back in 1896, that as long as facilities are separate but equal, then it's constitutional to segregate. Gaines versus Missouri says you can't continue segregating unless you can prove in lawsuits or in other spaces that the facilities you're providing are in fact equal in quality. And so that really touches off a very interesting period, which in my book, I talked about, the title of my book on the medical civil rights movement is actually called Deluxe Jim Crow. So it starts Southern segregated governments in just frantically trying to improve the quality of both Black schools and Black healthcare in the South in order to avoid having segregation declared unconstitutional. And what that does, it provides Black medical activists and civil rights activists with an excellent bargaining chip. They can really begin to file lawsuits that can, so there's going to be one of 2 outcomes. If, so for instance, if there's an all-white hospital that won't allow Black physicians to admit patients and won't allow any Black patients to be cared for, if that all-white hospital has received any public funding at the local, state, or federal level, then they must do one of 2 things. The city or the state must build a separate but equal Black hospital that they can prove is of equal quality, or they have to desegregate the existing white hospital. So they're either going to have to spend a lot of money to keep segregation in place, or they're going to have to desegregate. And so this really is a major turning point in getting better healthcare access, and actually a major step toward desegregation, even though white segregationists don't see it that way. So the medical activists are going at it from, let's push them as far toward integration as we possibly can, whereas the white segregationists are thinking, oh, let's fend off desegregation as long as we can. So there's this weird meeting in the middle point that really helps get a lot of legislation passed. So the South and the Southern poverty and its extremely high rates of morbidity and mortality become the focus of federal public health policy in the 1930s and 40s because of the things that I talked about at the beginning, that so many, such a large proportion of the medically underserved population was in the South. So my response would be, I do in fact think that they were paid on an equal basis. However, Southern segregationists were very good at finding loopholes. And so I'm guessing that even if they were officially supposed to be paid equally, they may have said that, so for instance, so this is what they often did, both with hospital admitting rights and with employment. They would say that Black physicians had MDs, but they didn't have residency training, and therefore they should be paid less than white physicians who did have residency training. The problem, of course, was residency training was generally, the programs generally barred Black physicians because they were racist. So it wasn't their fault that they couldn't get residency training, but they would use things like that to discriminate in some ways against Black health professionals. So you are correct that, you know, this was still a very racist and discriminatory time. However, the Black doctors were getting more and more successful in getting admitting rights in hospitals, especially white-run hospitals that accepted some Black patients on a segregated basis would sometimes give Black doctors admitting rights so they could treat their own patients. But it was hit and miss. It just was up to the individual hospitals. So I've tried to explain some of the reasons why the medical civil rights movement really gains power and influence in the 1930s and 40s. And then during World War II, all African Americans are really very focused on what was then called the double V: victory over fascism abroad and over injustice and racism at home. And so by serving in the military, many of the civil rights leaders, I had said many were doctors, but especially doctors who served in the military during World War II were in an excellent position to be able to say, I fought for our country just like all the other soldiers did, and I insist that I and everyone like me, you know, has equal rights. This is anti-American to continue to discriminate. So I'm going to talk briefly about Thomas Perrin. Basically, Thomas Perrin is one of the most famous 20th century people that you've never heard of. Thomas Perrin helped to establish the National Institutes of Health, the Centers for Disease Control, and the World Health Organization. And these are all organizations that were coming out of the major acknowledgement that healthcare was a universal human right, and it was very important for national defense during World War II. So there was all this new activity in health reform, and Thomas Perrin was really at the front of it as Surgeon General under Thomas Perrin. So I'm under Franklin Roosevelt. So Thomas Perrin was really helping to plan and implement the New Deal in the realm of public health. But the reason you probably don't know who he is because he has been really heavily criticized, and his influence has been minimized after his death, because as Surgeon General, he allowed the Tuskegee syphilis study, the study of untreated syphilis in the Negro to continue. That was the official name. So I imagine that a lot of you have heard of the Tuskegee study, which was the longest running, and many people would say the most awful medical study or research study in American history, because it allowed 400 Black men in rural Alabama, who were part of these medically underserved populations that I was talking about. It watched them when they became infected with syphilis. The public health service doctors would simply continue to monitor them. They would take blood samples. They even took samples of spinal fluid, which was extremely painful. They monitored them over a 40-year period until 1972, until finally the experiment was exposed by a New York Times journalist, and it ended. But Thomas Perrin's name has been, diminished, and rightfully so, because of his involvement in this experiment. But during the time that we're talking about today, he was a national leader. And because, often historical figures are not all good or all bad, they're a mixture. And for Perrin, he was actually very involved in bringing Black health professionals into the fight against public health problems across the country, but especially in the South. So, for instance, he was very active in bringing Black nurses into the military during World War II. But he was a segregationist, and he viewed these Black men in Tuskegee, Alabama, simply as medical subjects and not as full human beings. And that goes straight back to some of what we talked about last week in him having a scientific racist view of African Americans. So what happens as World War II and the New Deal really pump a lot of money and political power into public health programs. In the South, so one of the first national health legislation programs to pass is hospital construction, because the New Deal didn't build that many hospitals. It built some, but after 2 decades of depression and war, there's just a huge gap and a huge need for modern hospital facilities everywhere, but particularly in the South. So as federal money comes in, there's a stipulation in the legislation. So the Hill-Burton Hospital Construction Act, which was passed in 1946, it is the only piece of federal legislation that had a separate but equal clause in it. This is in a piece of federal legislation. And it basically said that if Southern states were going to build segregated facilities, if they were not going to admit patients on a fully equal basis, then they would have to provide separate but equal facilities. And they did that in one of 2 ways. They either did it in completely separate buildings in the same town, or they did it by dividing a single newly constructed building by floors, or even just splitting it straight down the middle so that Black patients were in one side and white patients were in the other. And that's exactly what they did in this tuberculosis sanitarium in Louisiana. They had it was architecturally speaking, exactly equal. There were 2 units built to the same specifications, one on the left side of the photo and one on the right. So it did dramatically improve the quality of care for all Southern patients, but especially for Black and for poor patients. However, it did not mean that the care was equal, nor did it mean that the treatment by health professionals was equal. So during this time, the blood supply remained segregated, not just in the South, but across the country. And so, you know, there would be separate closets for equipment, and things were labeled separately, and even just the experience. So imagine going into one of these hospitals as a patient who is sick and hurting, and you are admitted to a hospital room, and the bed is nice, and you know it's a new building. However, you see that everything that is used in your care is labeled colored. The blood supply, the medical instruments, everything, even the restrooms, everything is labeled colored and white. And that alone contributed to a lot of anxiety and just feelings of discrimination and racism that definitely negatively affected people's health outcomes. So I'm not trying to say that things were perfect. I am though saying that these deluxe Jim Crow health facilities were better than being completely excluded, and they were far better than the very old, out-of-date facilities that most Black patients were treated in. So probably the biggest deluxe Jim Crow hospital of all was New Orleans Charity Hospital. And it went from being, you know, this is the state of the hospital before renovations began. It was just a small aging building here. It became the largest, well, it was the second largest general hospital in the United States, and one of the largest in the entire world. So you can see it just dwarfs everything around it. So this was mainly from federal hospital construction funds that build a 20-story, 2,700 bed hospital. So it's enormous. It's comparable to the size of Johns Hopkins Hospital today, even. So there are, as I said, the architecture is split right down the middle. In the picture, you see two different towers on either sides, and one is the western wing was for whites and the eastern wing was for Blacks. And after they desegregated the hospital, they simply, changed the white wing to the west wing. But these were teaching hospitals for Tulane and LSU medical schools. And they really treated a lot of poor patients, which represented 2/3 to 3/4 of total admissions. But what you may have noticed is there's this tower right down the center. That's for private patients. Those patients were all white. They were being treated by white doctors in New Orleans, and Black doctors were not permitted to admit their patients, even if those patients were wealthy, because that private section was closed to Black doctors and to Black patients. So this is kind of the Charity Hospital complex. So it just gives you an idea of the amount of money that went into hospital construction and that really helped build most of the American hospital system in the years during and after World War II. What I wanted to close with is that Lewis Wright and the National Medical Association, the NAACP, all of these Black organizations, they were really critical in getting legislation such as hospital construction and even aid to medical education. The federal government really dramatically increases support for the entire health system during and after World War II. And it was the Black medical civil rights movement that makes sure that Black patients, especially in the South, were included in those programs. Not on an equal basis yet. It's a foot in the door and there's no going backward. Once once the Southern segregationists realized that they won't be allowed to completely exclude by race anymore, because so much public funding has gone into the health system, it opens all sorts of civil rights lawsuits, and that's ultimately how hospitals get desegregated. So picking up on a couple of themes, the statistics, the racial disparities in health problems, such as syphilis, tuberculosis, they were skewed by a number of factors because more Black patients came to public health clinics where those diseases were reportable. So if an equal number of white patients had come into public health clinics, or an equal proportion, then the rates would likely have been similar, if not exactly the same. But because white patients were much more likely to be treated by private physicians who were not going to report their cases because that would embarrass them, and they claimed doctor-patient privacy, the rates, when they're published in the Baltimore City Health Department annual report, the rates look as though there are really much, much higher rates in the Black population. So there is a combination of, so lack of access to healthcare and poor living conditions may have contributed to truly higher rates. However, especially with syphilis, and to a lesser extent with tuberculosis, the very success of the public health campaigns in Black neighborhoods and in the Black community makes the rates that are published appear to be much higher. So I had talked about last week with Frederick Hoffman, unfortunately, biostatistics and morbidity and mortality rates, if they're used properly and ethically, they are supposed to be identifying areas areas of the population that need the most help and where effort should be focused. However, that can, and in this case often does, result in stigma of those very groups that need help. And instead of recognizing that racism, poverty, and other factors are, social and economic determinants of health are causing these populations to have more, illness in their population. Instead, white leaders and medical professionals blame the people themselves. And I would say that's even more pronounced, if that's possible, in Native American health, especially with the Indian Health Service on Indian reservations. So the same kind of forces are at play there. But in Baltimore, the last thing I'll say about Baltimore is Baltimore could have been better, but it wasn't. Baltimore had the choice because Baltimore had Johns Hopkins, the person and the philanthropist. We had enormous philanthropic support, which meant that we didn't have to abide by the same rules as publicly funded state universities or state hospitals. Although Johns Hopkins Hospital admitted patients of all races to the hospital, it was internally segregated. So it's what I would describe as a biracial hospital. But instead, with the latitude that money gave us, we did not use it. And I see a comment here, politically, Black hospitals and Black communities had to continue to fight to get their fair share of public resources, once most hospitals became publicly funded.